Welcome back, everyone. Great to have you with us. We have a great session coming up. My name is Joe McKendrick, an analyst with Information Today, Inc., and I'm pleased to host now our next guest, Sanji Fernando, Senior Vice President, Artificial Intelligence and Analytics Platforms for Optum. Wow, what a great field to be in. And Sanjay is going to tell us about driving innovation, employing an analytics center of excellence. And we look forward to learning about, how to get things right, how to align analytics with your business. And Sanjay, please take it away.
Yeah, thanks, Joe. It's great to be with you all today, and I'm happy and excited to maybe share a little bit about what we've learned over the past few years in exploring new innovations, methods, capabilities in analytics and healthcare. We've been using analytics in healthcare for decades, as I'll describe, but we're really excited about some of the breakthroughs in machine learning and artificial intelligence and how we might be able to translate them back to benefits across everyone, as I'm sure all of us have to integrate our experience the healthcare system at some point in our lives. Just a little bit about the company I work for, Optum, and our parent organization, United Health Group. Not everyone is terribly familiar with Optum. We're a diversified health services business. Hopefully many more of you are familiar with our sister company, United Healthcare, which is one of the largest private insurers in the US today. But together, we form a United Health Group, which is a very large enterprise. We're in the Fortune top 10. We ended the year last year with $257 billion in revenue. But Optum itself represents a sizable portion of that revenue, over $100 billion. And while we're not as well known as other brands across the country, maybe even within healthcare, we do work very closely with United Healthcare as well as many other entities across the healthcare spectrum. Patients, consumers, life sciences companies, state governments, probably most importantly, providers, both in practices and in hospitals. And our mission is quite simple: to make lives healthier and make the health system work better for all of us. And from my organization, my standpoint, we've got this unique position where we can really understand the healthcare system and, more importantly, hopefully, leverage the data being generated across that system to make all of this better for all of us. It's a hard challenge, but something we're really excited to face into every day. So analytics and artificial intelligence go together, but analytics have been used in healthcare for decades. They've played a central role in helping us improve the healthcare of patients for decades, but also improve our healthcare system, especially here in the US, by trying to understand how it works, how great outcomes are delivered. But that can be really hard. As you can imagine, the human being is a pretty complex organism, and there's a lot of heterogeneity in us as human beings, and that's reflected probably in our healthcare system to some extent, to a great extent. There's a lot of heterogeneity because it's adapted to a very complex problem, delivering healthcare. Analytics in healthcare over the past few decades has strived to try to get to common units of analysis at times, so we could understand better what's working, what's not working, how costs are distributed, how care is distributed, how it might vary across this very heterogeneous system. And that's not an easy task. For decades, we've used rule-based analysis to try to get at these common units of analysis if I see this, this should be classified this way versus that way. But we know that rules can be constraining at times. And so in an effort to try to get better at this, new methods have been introduced, sort of statistical reasoning and structured data, where we try to best fit to the data that's available to us, has been an incredibly important part of healthcare, and something we've used to understand trend, understand how to serve populations better. And now, in the last few years, with the renaissance of artificial intelligence, primarily driven by machine learning, we now have new tools to allow us to, almost to some extent, but not completely, disregard that heterogeneity, if we can sort of not worry about the features or the structure that we pass into a method. Can we still classify things? That's sort of at the heart of some of these new breakthroughs like deep learning, a type of machine learning. And with the application of these new methods, we're now on the cusp of really saying, how can we apply the best methods with what people need to make great decisions, whether they be a provider or a payer or a consumer? How can we grab the best methods, can apply them to a problem, provide people with information that synthesizes a very complex information space, and do that safely and appropriately, but do that in a way that helps people make better decisions and augment their intelligence. And that's what we're really excited about, and the journey we're on with this type of innovation. So many, if not all of you, may be familiar with a lot of the breakthroughs in healthcare using artificial intelligence, specifically machine learning. A lot has been driven by other industries and technology leaders who have taken image analysis, text analysis, and recognized that we can reapply that. Specifically in the case of deep learning, we can leverage transfer learning to retrain these capabilities to go from classifying pictures like a cat versus a dog to actually identify diabetic retinopathy in this example. So that's been really exciting. At United Health Group, we have lots of possible use cases to apply AI machine learning. And in the past few years, our focus has been on applying that to the administrative side of healthcare. Somewhat, as I explained to my kids, the very boring but incredibly important part of our healthcare system, where many, many skilled professionals need to understand clinical and reimbursement and policy, and use that to make sure folks are getting great outcomes and at the appropriate level of care and level of reimbursement. What we've been doing is looking for those use cases where we apply machine learning and speed the approval through that system when both counterparties, say provider and payer or patient and provider, all agree in the answer. And can we get to yes? So for those of you not familiar with healthcare, maybe even those who are, I'm always learning every day about our very complex US healthcare system. There are numerous, we feel, opportunities where you can apply machine learning maybe to get greater efficiency, get to those approvals, improve the decision making. Prior authorization are areas that we're looking at, understanding where people go to get the best care and the best outcomes after a post-acute setting. An important part of our healthcare system today, as we begin to drive more distributed value, is risk adjustment. Equally important, if not more, are the quality metrics that go along with that to make sure everyone's achieving the outcomes that we want them to achieve. And probably most exciting is how are we getting better at preventing chronic disease, preventing costly healthcare utilization, and improving the well-being and lives of folks. And then if we think about healthcare operations, just being able to process claims, ensuring provider directories are accurate, coding for billing. These are all great examples of where we can try to apply machine learning. Given this universe of opportunity, it's always been incredibly important to us to understand how to get started. And hopefully, I'm sure there are lots of ways to get started. These are some of the things we've been focusing on, not all of them, but some of the key things that we focus on to understand where we should focus first. First and foremost, whether it's a machine learning solution or any sort of technical or business solution, understanding the opportunity is incredibly important. What are we trying to do? Who are we trying to serve? And how does this solution deliver value, cost savings, or improve patient and even provider satisfaction? We're always grounded in that quadruple aim, which is very hard to accomplish and optimize for, but is sort of at the center of what we try to do every day. Once we understand that opportunity, the next big question for us is, what type of data do we have? Oftentimes, if I go back to the case example from Stanford about diabetic retinopathy, when we read papers like that, our enthusiasm says, "Hey, let's go try to build that or train that or look up that GitHub repo and see how that model works." But then we have to ask ourselves, like, what is the business we're in, and what is the data that we have? In our case, we didn't necessarily have a great deal of retinal images. We didn't operate large ophthalmology practices or necessarily have access to that data. So one question we always ask is what is the data to be learned from or trained from? And that's an incredibly important step in this process. The third thing we try to look at is how well labeled is the data to train. Now, this is not a showstopper, and without getting too technical, but we absolutely can look at unsupervised learning. But labels are essentially the answers, or the answer key. Like, what was the decision made? What was the diagnosis made? What was the procedure done? What was the answers that were generated by smart people with great credentials and great license? And what can we learn from their decisions after reviewing this input data? Those are labels, and we look for those often because that represents a supervised learning opportunity. And those tend to be easier to implement. Not a showstopper again, but we like to go for that low-hanging fruit whenever possible. And then finally, what level of explainability do we need? What might we be able to infer that allows us to maybe prioritize someone's work queue, move it to the top of the list, for instance, or speed to approval, but may not require us to provide direct mathematical causal relationships. That has tended to be harder, though every day now we're seeing new breakthroughs to understand those causal relationships and help us implement them in sophisticated models. Breakthroughs happening at academic organizations, at large corporations, and we are confident that we will have more tools in our toolbox to support greater explainability. But we do ask ourselves, what is the bar we need to reach here? And how does that explainability help us understand incredibly important facets of how we might use the model, especially, not to be discounted, health equity and fairness, as we think about how to create a more equitable healthcare system for all of us in the US. So in order to train machine learning models, um, we almost have a massive paradigm shift in how we think about software. Um, since the advent of computing and software development, I've heard other smarter data scientists and artificial intelligence experts describe programming as micromanagement. But now with machine learning, we're actually driving towards more goal-oriented management. We're presenting information to systems and expressing the goal we want to achieve, but we're not explaining how to achieve that goal. And I think Peter Norvig spoke about this once years ago. It does change the way we think about how to build and train these solutions. It drives us towards a more experiment-driven approach, where initially we might try to design and train a model. And more importantly, we establish the criteria in which to evaluate the performance of that model. But then we track that experimentation and see how well it meets those goals. And if over time, after much experimentation, we find a model that works, we might then be ready to deploy it as part of a broader business or software product solution. We use sort of best of breed deployment methods to do that, and then integrate it with that software process. But that's really not the finish line. These models do improve with more data. We do need to monitor them and see if they're operating as we expected to. But also with that additional data, we can improve them over time. And so we repeat the cycle. And probably most importantly in this process, as we've learned, and we have so many professionals in this field who are focused on this, but not only evaluate that model for performance, but fairness and health equity. We may not be able to fix everything in healthcare, but we can understand how the model outputs might affect different individuals of different protected classes, demographics, such as age, race, and gender, or gender orientation. We also are at a point in time that we're all benefiting from lots of great breakthroughs in technology and hardware, but also in models of public computing and open source tools that allow us to put together what we hope will be best of breed tools today, but also add to this collection over time, where our company has chosen to use specific cloud providers like Microsoft, but with their help, as well as the contribution of so many others in the open source community, we can use tools that allow us to manage experiments, manage data transformations, execute and run models and inference at batch, integrated with very complex data elements like scanned document images and things like that. And more importantly, evaluate our models for bias. And so this combination of tools are the things that we use, and we're constantly iterating on this to see if there are new tools that can be added or swapped out. Again, leveraging some of the great work done by technology companies, cloud providers, but also contributions across the open source community to make this process not simply seamless, but more performant and productive and effective. So what does an innovation look like? And I'll share with you something we did a few years ago that really sort of set us down this path and recognizing not only how well some of these models can work, but how to think about our business and how to think about integrating machine learning and artificial intelligence into our products and services. So in our revenue cycle business, which is where we support hospitals and providers to get the appropriate reimbursement from insurance companies or payers. We have a service where our Optum physicians can render a third-party review of the care of a patient to support their request and reimbursement level for those services and that care. Oftentimes, historically, when hospitals tried to do this, they asked their own physicians who were incredibly focused on delivering care for you in that care setting to also do this administrative step to say, hey, should this be submitted for a third-party review? And it can be a burden. You want those clinicians focused on your care. You want to look for opportunities where we can reduce the administrative burden for them. And so with the help of a trained deep learning model that we created, we could now have that deep learning model do that review for physicians. We trained the model both on the medical chart and clinical notes from the case, as well as the evaluations historically that our own physicians have done. So for any new case, we can pre-vet it almost and provide that hospital system or that provider a determination of what we think would be the likely outcome if a person reviewed it. And now, automatically, that could trigger that third-party physician review without any work or burden on that clinician or caseworker or nurse in that care setting. We could do that for them. Now, the reviews still go to a person, a clinician, a board-certified medical doctor, but all the work to decide what are the most important cases, the most complex cases that warrant that third-party review can be delivered to that person. And this is a theme we see throughout healthcare where we want to get the most complex, the most difficult decision-making to the folks with great license to drive that decision-making. But if there's things that are more routine or not a really good use of their time, can we move that to the side or get that approved? And can machine learning help us? As I mentioned, in this use case, which we built a couple of years ago, we adopted this very, experiment-driven approach to test different modeling architectures, to test different approaches, to represent language, like back then it was fast text, to represent the model architecture, in this case an LSTM, and how we could understand if the model was doing anything any better than a more interpretable regression-based model. Regression at that time was our baseline, and we wanted to try to beat that and beat that in a big way because we knew how complex these models could be. We also had some real challenges, especially with our partners in the business, especially the clinicians who would benefit from this, in getting to our black box problem, as we sometimes call it. Machine learning models, specifically these deep learning models, can struggle with interpretability. They literally turn the text into vectors of numbers. And these vectors are passed through a series of connected equations. So terms like cardiovascular disease or atrial fibrillation are just numbers to these models in some cases. And sometimes when you push all that information to a model, establishing a direct causal relationship can be challenging. And so almost from a QA standpoint, we were keying off the right elements in the information that was presented to us. And so we had to build some tools, not to solve for true causality, but to pull the curtain back a little bit on this problem. One way we used back then that we even use today in some circumstances is using attention weights. And with this, we could start to understand what the model was keying off of. And almost as a QA tool, we've used it to present back our test runs of the model to physicians to make sure that the same things they saw in this very dense, complex information in text would have been the same things they keyed off of, as opposed to some maybe random words or information that didn't reflect a direct relationship with what should be keyed off of in this text. And this was really important for us from a QA standpoint, but it had a much broader utility as it helped us understand and build some understanding of what should be highlighted or keyed off of the information in a big way. And so this has turned into almost like a feature now of how we use these models. We also use, as many data scientists and machine learning professionals use, a number of statistical tools to understand how these models are performing. Classically, many of us leverage a receiver operator curve to understand how well a model might be working versus sort of a random choice almost. But that's not always the best way to understand what business or outcomes you want to optimize for. And so in this case, we found that the precision recall curve was incredibly important because we wanted to really focus on not missing any cases that did warrant an appropriate third-party physician review. At least that's what our customers and our product users wanted. And I show this slide not to ask you all to understand these curves, but recognize that understanding your business problem is going to be incredibly important to understanding how you evaluate the performance of your model. And just seeing someone drop the term AUC in a conversation does not necessarily mean that that solution is going to work for you. It does take a little bit of work and great partners in your data scientists and machine learning engineers to get to that right answer, but it's incredibly important. As machine learning professionals, we are familiar with this confusion matrix of where the model might be right or not right. But it can be an incredibly hard problem or hard concept to convey to our partners, our clinical partners, maybe end users, or even business partners. And so what we've tried to do is really try to create better mechanisms to have that dialogue so folks can understand what the trade-offs are and how the model is performing and where we're missing and where we're getting things right. We built on this to create even more visuals. This is where we combine sort of the visual elements of a histogram to a confusion matrix to really get a sense of those trade-offs. And at that point, it led to some new features that were considered. We didn't ultimately implement it, but we know there's a threshold in here where we cut off what is a recommendation in the model, and we dabble with the idea of like, do we allow a user, a business user, to move that around and tune this to their needs. And we're still continuing to evaluate whether that's a feature we want to implement, but you could imagine having the right context to understand that is incredibly important as well. And while this is a work in progress, we found these histograms visually helped users, especially non-technical users, understand these trade-offs a little bit more. And if you're a business user out there looking at this and saying, hey, this is too complicated for me, I've got to rely on my data scientists to figure this out for me. You do. but we should all own this. We all need to understand this to get successful machine learning and AI solutions out the door. So it will take time, but we're sort of all in this together. So as I think about what we've learned, you know, some of these are no-brainers. They're, nothing, earth-shattering. Some of the basics we need to do when we think about any successful solution. But they're even more so important in understanding how we maintain and build innovative machine learning products. Starting with the right problems and assessing our ability to solve them. And then recognizing that there's a loop here to gather and improve models and solutions. And sometimes they don't work out. If you don't meet that bar criteria, that's a reality. Sometimes we assume that we're just going to build a solution. But if we don't have the data or the modeling techniques to meet the criteria or goals that we need to meet, there may be a situation, and there often are situations where you can't build that kind of model. And then we need to stop or reassess. But if you do get past that important hurdle and start building your solution around it, measuring the benefit, evaluating the impact and around fairness is incredibly important. And then you got to recognize that with more data, more understanding, we're going to need to improve these solutions over time. And then we go back into that loop. And so it's a pattern that we're continuing to build on from those first solutions we designed a few years ago. And they're incredible breakthroughs in technology, in causality, and symbolic logic that we're exploring every day. Breakthroughs that we've made small contributions to, but others in this field are making massive contributions to. And we're excited to take advantage of those. But I think for now, I think we'll follow these steps really to drive that innovation through our portfolio. And I think with that, Joe, if you're still on, happy to field any questions that might have come through.
Thank you very much, Sanji. This has been great. Very fascinating case study. How you brought this all together, and you're on this journey to introduce more intelligence into the operations across the whole healthcare spectrum. Great stuff. And we invite our viewers, and maybe readers too, but our viewers to Sanjay's standing by for your questions, and by all means, if you have questions for Sanjay, how he brought this all together, how he's making this all work, please enter them into the space on the right-hand side of your screens. And Sanjay, I gather from your session, you've been taking very deliberate, careful steps to each step of the way to ensure that the data is correct, the models are correct, the business users are on board. I'm thinking back to for example, IBM Watson. I love IBM Watson, by the way. I think it's a fantastic platform and a fantastic development, but it had some issues over the years, right? The creators of IBM Watson found it's difficult to kind of replicate or to take the messiness of the healthcare decision-making process, at least on the clinical side, and bring that into a machine. Do you encounter any skepticism among clinicians, related to that? Is that something doctors are reluctant to? With the idea of having a machine kind of making decisions that they've been making all along?
Yeah, it's a great question. And, unfortunately, I don't know a lot of the details on Watson. I unfortunately get a chance to work with it to understand how it works. But you're right. There's a lot of, I use the word heterogeneity, which might be too nice a word. It's a messy business, all this information that we have to process and understand. I think some of the breakthroughs in machine learning, specifically deep learning, have allowed us to take on a great deal of that quote unquote messiness, like that differences in datas and types and the lack of structure and commonality in that information in a way that we've never been able to tackle before. So that's one thing that's in our favor. With regard to clinicians, they're an incredibly important part of any of this and part of this journey. I think, what we really focus on is maybe not taking people out of the loop of decision making completely. We'd like to remove decisions in some cases, very specific cases, where it doesn't add a lot of value. It's not a good use of their time. But what we really focus on is augmenting and supporting the decision itself. And so I think that's like that augmentation is really where we're going in healthcare in the application of machine learning. And let me get very real. Like, I mean, some of these medical charts are like 300 pages long. And so if a clinician meeting you, seeing you, spending 25, 30, 40 minutes with you is presented with a chart that's 300 pages long, they could be spending 2 hours just trying to read that. So what can we do to summarize that? What can we do to pull out what's important? Can we do to reduce that administrative burden so that categorizing or capturing the information that they learn from your encounter is seamlessly distributed across the system? That's where I think the real opportunity is, where our capabilities intersect, I think, with what clinicians really want in that setting.
Fantastic, fantastic. Along those lines as well, you've covered both in your presentation. You talk about both the kind of the business aspect of healthcare as well as the clinical medical aspect. Do you find that the same tools are adaptable to both? The finances, hospital finances, or treatment, the finances of treatment protocols versus the actual medical information that's being worked with?
It's a great question, and I'm not too up on my general ledger and accounting and finance stuff as I used to be. But if I extend that analogy a little bit, like the areas that we tend to focus on are very domain specific, I'd call it, like healthcare specific, like a clinical chart review for maybe risk adjustment, for example. Or a third-party physician review. There are other aspects of artificial intelligence, maybe call routing or conversational AI when you have a large call center, or maybe optical character recognition (OCR) when you're scanning a document and want to transform it into what we call text or ASCII text. Those pieces, those building blocks, those capabilities, we could try to recreate them, but my attitude is I tend not to. I think companies in the market, whether it's Microsoft, Google, Facebook, Uber, others, are building those capabilities every day, making them better and more performant. And I want to stand on their shoulders a little bit and focus on the more domain-specific things that maybe they're focusing on, but I know we need to help our business move forward faster and deliver better quality and outcomes for the folks we serve.
Fantastic, fantastic. Well, we're out of time here. Folks, Sanjay is going to be, if you click over on the networking tab, the networking symbol over on the left-hand side of your screen, you can go into an area where you can speak, I guess, more private basis, one-to-one basis with Sanjay with your questions, learn more about the work he's been doing at Optum and the work with machine learning and artificial intelligence. Really great stuff. And I urge you to, chat with Sanjay. This is your opportunity. Again, Sanjay, this has been a great presentation. Enjoyed learning about it, and lots of information to think about here. And keep in mind next time you go to a doctor or whatever, what's going on behind the scenes. Thank you very much for joining us today.
Thank you for having me.